opens and he's.
Okay, so the I just got notified that the recording is in progress. So the I should be careful on what I say today, I believe. So the hi everyone, nice to meet you. So the I'll be talking a little bit about the risk adjustment today, and I believe everyone is quite familiar what risk adjustment is, and the I'm a little bit kind of shy to talk about risk adjustment because I may reveal my ignorance and not a bit stupidity on the how I see things, but please bear me with it, and I will try my best to actually to explain kind of what I've been thinking about it. And it actually all comes down to how this thing started and how actually I'm here. So I'll tell you a little bit about the background, why I'm here today. And this all started with this health affairs article. So I've been in the healthcare field a little bit, now about a decade. And I've been actively following all these health affairs articles, and specifically, I've been following the health affairs forefront, previously health affairs blog, because I see a lot of opportunities and different perspectives from the healthcare thought leaders. And one article caught my attention. It was by Anish Chopra and Adam Bowler and Gary Bakker. And for those who actually don't know these names, I think Anish was the if I remember correctly, he used to be the first CTO of a White House during the Obama administration. And then since then, actually, he's been in the healthcare field, working with healthcare.gov and doing a lot of different things in the healthcare field. He has a company at this point, running a company named Care Journey. So there are a lot of ACOs actually rely on Care Journey data. And the Adam Bowler used to be the director at CMMI. I think that's my kind of knowledge. I may be wrong, but currently he's running a private equity firm called the Rubicon Founders. He also founded a company called the Landmark, which is very successful home visit kind of provider groups. So these guys are the kind of apparently thought leaders in the industry. They've been doing a lot of value-based care, and they actually published this paper called Risk Adjustment, It's Time for Reform. Very provoking title, and I took a look at it. And we all know that the risk adjustment methodology has been for some time, and it may be a bit of overdue for fixing it. So I tried to look at what are the ideas, and there are many different ways to fix. And actually, I resonated what they have been saying a lot because what they've been proposing was simple enough to do in practice. That's why I decided to make some comments, and I decided to edit a little bit of my perspectives on the things that I would want to add on top of their approach. So I posted on my LinkedIn. So then, thank God that Samantha here found me on LinkedIn, and she was, your LinkedIn post. I think you wanted to. I wanted you to present this LinkedIn post to the group. That's kind of why I'm here. Thanks for inviting me, Samantha. And by the way, actually, if you have any questions, please stop me. And I want to make it as an interactive discussion as possible. In that way, actually, I can focus better on where the audience is at. So if you have any questions or if you have anything you don't understand, then please just stop me and ask the questions. And before going into the detail, I'd like to talk about a little bit of myself. And it's important to understand what kind of things I have done so far, and what do I understand, and how I view the risk adjustment. As you can tell, actually, I don't know if you can tell or not, actually. So sorry, I'm an engineer by training. So I'm not a healthcare professional, and I actually don't have much of a relationship in the healthcare field during my school days. So I got my machine learning PhD from UT Austin. And right after graduation, it was a time around everybody talked about big data. It was around 2014, 15. I don't know if you remember, but if you go anywhere, people started talk about AI and big data. Even now, people talk about those things. But at that time, all the big company executives, they needed to do something with the AI and big data. I think I was very lucky because I was getting a degree in machine learning, and I was starting up a company in healthcare. And I was claiming that I was doing machine learning, big data analytics for the risk adjustment. So people loved it. So I was running a startup called Accordion Health. And essentially the pitch was we can analyze claims and potentially all supplemental data to uncover all hidden opportunities for you guys. So we did that. For doing it, I needed to study a lot of risk adjustment mechanics, all the algorithms, underlying algorithms, different statewide Medicaid risk adjustment models as well, how actually data get processed and all those things. And it's more of a self-taught. But I studied risk adjustment quite a bit during the startup period. I got lucky, and after running that startup about 3 years, I sold my business to a company called ApolloMed Health. ApolloMed Health is located in Arlington, Virginia. So probably you guys may or may not know of the company, but it's near the DC. They actually do a lot of ACO management. So I moved to ApolloMed Health after selling my company. I stayed there a little bit, involved in some of the ACO operations. Then I did my second startup, looking at the DCE, direct contracting entities. And there I created another software platform looking at the risk adjustment, processing claim files, CCLF from CMS. And I just wanted to make something very lightweight for those small ACOs to look at their data easily. So I was doing the business, running the business about 2 years. Then I met CEO from ApolloMed, which manages one of the biggest HMO and the ACO in California, and also publicly traded company. So we met, and the Apollo Apollo acquired my company, second company, and that's why I moved to Apollo, and I'm here. So over the kind of short period of my career, I started my career with the risk adjustment, and I still remain in the risk adjustment field. And I'm not quite the risk adjustment, officially trained, but on the side knowledge of doing a lot of computer programming around the risk adjustment, I became very interested in it. So that's my kind of short history about the risk adjustment. So then let's get back to the original post about this risk adjustment. Anish and Adam Bowler, and they want to fix the risk adjustment. They want to reform it, and we try to understand. We need to understand what's wrong with the current model, right? And probably everybody agrees. So the risk adjustment is actually in a hot topic. OIG always look at some of the risk adjustment anomalies, and they find all the big players here and there. And a lot of people claiming that it's just a gaming mechanism. People make more money by doing a risk adjustment. That's kind of one perspective. But at the same time, risk adjustment is needed. Without the risk adjustment, you are encouraging adverse selection in the either ACO or any value-based care arrangement. So it's like a necessary evil. So that's why people don't know what to do with it. And I wanted to see how can we fix those things. So these are the kind of simple treatments in the health affairs article. So they propose 2 options, whether you can use individually or they can combine in a single solution as well. One option is, rather than making conditions captured every year, for those chronic conditions that do not go away, why don't we propagate over many years? That's the one idea. And I particularly resonate with this idea quite a bit, because when you're working in the risk adjustment field, a lot of time is spent on something called a recapture or reconfirmation. And those are the things actually reconfirming those chronic conditions may help the treating the patient conditions, but sometimes it overburdens to correctly code on the claims, and those communication burden between PCPs and the ACO, while either MA, it can actually get sideways, and it gets actually lost track, and just the burden itself, and sometimes actually trying to gain the system on that aspect make the entire experience worse. So that in that way, if we just make the chronic conditions that will be there anyways, can we make just propagate over time, that actually make it a bit less burdensome in the coding. So that actually I could get the idea. So kind of overall. So that's option one. And option two is a little bit controversial, in my opinion, is to use approved coder rather than actually using the coding from the doctors or actual providers within the network, or in the claims. Why don't we use the approved coder to identify risk adjustment eligible diagnosis codes from the medical records, and treat those conditions as RAF alone, and that's kind of the period end of the discussion. So that's kind of that also makes sense to some degree. That may actually reduce the kind of interpretation of the how you would code from the medical records. If you're actually have a way to select the unbiased and approved coders. And that also comes with a bit of a cost, because you need to pay for those coders as well. So the option two is a little bit of a question, but the option one, I could get that idea. Then this goes to my LinkedIn post. So I was reviewing it, and the one actually idea they were discussing is Anish and Adam Bowler. They actually were debating that, because we are making those chronic condition permanent for the demonstration period, which actually applies usually the ACO program. The ACO program usually runs about 5 years. So for those demonstration period, let's not add any additional conditions at all. That's kind of their argument. I think that one is good. At the same time, it may cause some issues, because some patients may just really acquire new conditions over time. And I just wanted to have a mechanism to add additional conditions, but they are not by just the random claims. So my suggestion on top of their health affairs article was that what if we use the option 2 idea to add new conditions every year, meaning that let's have the chronic conditions propagate over a year, but for those who need actually to add those new chronic conditions added every year, the coming year, why don't we actually pay for those coders from the ACO's pocket, and have those codes added for that particular year, in a way that the ACOs can decide whether those medical records are worthwhile paying for the additional coder fee, so that the ACOs only recommend those new conditions. Those are for sure for them. So that they don't randomly just flood, give all their data dumps to the coders. So they limit their kind of recommendation to the coders. They'll add those, and when those codes are added for the population, it'll be more accurate to describe the actual population's conditions in that way. That's my recommendation. Then, as I was preparing this talk, I became curious. They said regarding the option 1, it's a very easy to understand in my head that if we make the chronic condition propagate over time without being concerned about recapturing, it seems like it's easier or less burdensome for providers. But how does it actually affect for predictive nature of the HCC model? So I did a little bit of experiment with the ACO data that we have. ApolloMed, actually, we run a kind of fairly successful ACO by ourselves. So we took our ACO data and I compared, and if actually that helps in the predictive nature of the HCC model. So what you are seeing here is the original HCC model. So here is the 13% R-squared value. If I actually make the chronic condition that is captured 2 years ago propagated to the current, and if I predict the next year's spending, actually R-squared values goes up. It's not much, but it's actually it gets more accurate. That actually was verifying the hypothesis and the kind of validating what Anish has proposed. So I think to some degree, although it needs more deeper research into this topic, but if we actually make the chronic conditions propagated over time, and if we have a mechanism to change in a way that to make it more accurate over time, I believe actually the predictive nature of the HCC model may improve. I think that's kind of something promising from the topic. And I also decided to go one step forward. So my major is in machine learning. So I wanted to try, okay, so the HCC model is built on top of the statistical method. And there are a lot of other predictive algorithms out there. In the context of machine learning, there are a lot of cool algorithms that may do a better job than just simply using coefficient and the linear regression type of model, which is now the HCC. And there are a lot of other variables to consider. So when you actually look at the ACO risk adjustment and the benchmark, how benchmark is calculated, it's not just about the risk adjustment. It's about the historical spending. It's about the regional benchmark. It's about the now with the ACO reach, now we need to think about health equity index as well. There are a lot of things coming to the play. So I was imagining if we are reforming the risk adjustment model, can we just come up with the better model itself rather than patching small solutions on top of the existing model? If we were to do it, if we were to make a completely new model using some machine learning techniques, and this is a bit of a preliminary research I'm sharing today. So I took all the data from our ACO. I calculated the HCCs. I added the historical spending data per members. I'm adding all the SDI, SBI, ADI variables. And I put those into the machine learning models, whether we can build up better predictive models, which potentially may replace the current HCC model. So here is the kind of current model stance. It's about R-squared of 13%, which is okay. It has some predictive, performance, not great. If we use, these are 3 basic machine learning models. Actually, predictive performance goes up, by a lot. And there are all these different metrics, performance metrics that actually we look at when you're evaluating risk adjustment models. What I realized is just changing from a linear regression model that is currently the HCC model to a machine learning model with the more variables, including health equity index and the historical spending, we may be able to come up with the more predictive risk adjustment model that may actually be helpful for planning out the ACO business after all. That's kind of quick exploration I did with the excuse of presenting today. That's the end of my talk. And I don't know if you guys have any questions so far, any comments or feedback. If you want to have something on the offline, here is my email. And you can always find me on LinkedIn as well. My name is fairly unique on the LinkedIn site. So you can find me fairly easy.
Great. Thank you so much, Dr. Park. We did have a couple of questions if you have the time to.
Oh, yeah, sure. Yeah. Okay. I see the chat. Yeah.
Okay.
Yeah.
So Sam, can our participants ask their questions in a dialogue?
Yeah, Rob, do you want to go first?
Yeah,
Thank you.
happy to. And Dr. Park, first of all, thank you so much for being here. Very, very interesting discussion. Risk adjustment is obviously a very controversial issue. I know on the provider side, every physician believes their patients are sicker than everyone else's. But it's tough to establish that. And I was very interested when you were talking, about the article and the concept of using approved coders. I'm interested in exactly who approves the coder, because it's who approves the coder is going to be very, very important. If it's on the payer side, if it's on the provider side, or if it's sort of some third party like a HEMA or AAPC. So I just wanted to get you to discuss that a little bit.
Thanks for the question. And I was also questioning that part as well. And to be honest, the idea is not mine, and actually it's Anish's idea. So actually, I don't know what Anish had in mind. But thinking about where they are coming from, they are specifically talking about the ACO side of the model. So when I read the paper, the health affairs article, most of the discussions go around the CMMI models. With the demonstration period, there are basic assumption behind this risk adjustment reform is that there will be someone, and that someone is CMS. So I think their viewpoint is CMS is the ultimate paying entity, and they actually need to have some jurisdiction of the either approval of the coders, and I think they need to essentially have the some say in the kind of validity of the record. And if I just impersonate where those authors are kind of from, I cannot be sure whether actually this is their opinion or not. But I believe they may be thinking that the CMS, either CMS approve it, or CMS kind of delegating some other entity to approve those coders. Yeah.
Gotcha. Yeah, and obviously a lot of providers, the vast majority of physicians do not code their claims themselves. It's done downstream, either within the practice with an expert, or actually they outsource it to an entity outside the practice. So, and I think you alluded to this, if you are requiring some third party to come in, that could impact revenue cycle operations and would drive up cost. Obviously, if you had some sort of third party.
That's right.
And again, there has to be a dispute process, because if they code in a certain way that the practice believes is inaccurate, you've got to have then an arbitrator in the mix to sort of be an intermediary between the approved coder and the practice. So it's exciting, but you can see a lot of bureaucracy and a lot of administration potentially associated with it.
That's right. So I agree. So the general kind of sentiment, I cannot represent all the providers in the nation, is that, but the way I feel working with the providers that we have, medical claims and the medical records, there are two different things. Medical records, EHRs specifically, providers have the ownership and the authorship, and they treat it as that's data they trust. Usually claims, there are a lot of them are, as you say, Robert, they are a bit detached, because a lot of them actually get outsourced in the billing process. So a lot of times doctors actually don't know what's being coded either. So those are actually make a little bit more burdensome. And when it comes to this risk adjustment intervention from the payers and ACOs, ACOs asking them to, you need to code this, you need to code this. A lot of times actually it gets more friction between multiple parties that are involved in the process. So that's why this risk adjustment issue is very complicated, either to getting approved coders or third-party coders, or doing by themselves. there isn't much of easy solution. Yeah.
No, I appreciate that. Thank you so
Yeah.
much.
Thank you for the question, Robert. And Dr. Park, we have another question or two. You still have time?
Yeah, I have time. Yeah.
Great, thank you so
I'm
much.
yours.
So Betty, I know you had a question in there. If you want to unmute, Betty is a colleague of mine.
Mhm.
Absolutely. Thanks, Mike. Thank you for the talk, Dr. Park. I actually read this article a couple of days ago on LinkedIn and almost commented on it myself. The one comment I will make about the coding option is, as a dually certified coder myself, it's kind of common knowledge that you can get 3 coders in a room and get 5 opinions. Unfortunately, as you said, the process of medical documentation versus the process of coding a claim for submission and adjudication for payment are not the same thing. And so there's lots of different interpretations of some of the guidelines that are there.
Yeah.
My question had to do with the auto-piloted option.
Yeah.
One of the things that we see with the current risk adjustment model, which does require that there be documentation of a clinical assessment and some type of treatment plan or status.
Yeah.
If we go with auto-piloted, how do we ensure that the patient is receiving clinically appropriate care for that condition?
I think that's a good point. So it comes down to it has both sides. So because the CMS is requiring as you say, Betty, so the care plan for the treating those conditions. But in reality, in my opinion, my opinion, I need to double quote. The people who are worried about the gaming nature is that actually the plan is just the document only. So the risk adjustment dictates the coding, and a lot of documents are generated. But I think people who complain about the gaming nature of the risk adjustment is that actually there is no follow-up. And a lot of times where OIG come in and they're identifying the risk adjustment waste and fraud is because there is no evidence of those treatment records. So I think it comes down to which side is a bigger. So the code is because they code and don't treat. That's our burden. And if just have autopiloted conditions and go on it, there may not be much of the treatment from that because they're not checking it. So there will be also another waste because they're actually PCPs may not be managing those conditions in the end. So to some degree, we may need to statistically analyze, although there is always a limitation in statistics, but we need to compare which side is bigger waste if we need to make data-driven decisions.
Thank you.
I can absolutely respect that. I think one of the things that I often hear when I do risk adjustment, any type of education is, some of these conditions shouldn't need to be captured every year. And amputation status is a clear example. On the other hand, I do believe that it is clinically appropriate that if your patient is missing a limb, that you would want to do an annual assessment. Are they developing contralateral arthritis? Are they, do they need some type of prosthetic adjustment? Do they need, some type of gait training or something like that? So yes, they're not going to grow their leg back, but that doesn't mean that they shouldn't be assessed on a regular basis to ensure that they're receiving appropriate care for that condition that will not change.
I actually resonate your comments a lot. Yeah. So I think at the moment, the way I take the Anish's article is it's a one of many other proposals. I think there are a lot of other proposals to reform the risk adjustment. Another idea I came across is why don't we expand the 1-year cycle to the 2 years or 3 years? So meaning that what if we just it's rather than the autopiloting HCC, but what if we just make the 1-year window of the capturing diagnosis code to the 2 years? So that's kind of another proposal that may be worth exploring as well. And those ideas may be evolved into a somewhat more complex, but I don't want to make it too complex because as you make it complex, and there'll be a lot of other kind of burdens coming along. But another idea is for amputation, it's worthwhile to check every year, but should it be every year or should it be every 2 years? Or should it be every 3 years? So those things may be kind of able to flexibly adjust it. I think there'll be in the end a balance between overburdening doctors and the overcoding. Yeah. So I think we just need to figure out what is the right model, not burdening doctors at the same time, correctly representing the current condition status of the patient and make the accurate payment for those the capitated groups. Yeah.
Great. Well, thank you so much, Betty, for that question, and thank you, Dr. Park. There's one last question, and you had mentioned early on in your presentation about the ACO REACH model, and it's so new, and results haven't been brought in. You mentioned about the health equity score, I believe, or you may have used a different term. Did you research that? I mean, because everybody I speak to, even folks who are actually participating in it and had proposed a health equity plan in order to be awarded, it's just so confusing. Did you learn anything that maybe you could share this with this payment models work group team?
I actually dig into a little bit. Yeah, but I haven't followed up the latest announcement whether actually there was any further development. So that my knowledge is a bit outdated. So as far as I know, it's the official name is called the Health Equity Benchmark Incentives. I think so the HEBI, Health Equity Benchmark Incentive. So the way actually they decide is there is an index, Health Equity Index, named ADI, Area Deprivation Index. So it's developed by I think AHRQ in the past, and I think it's currently managed by the University of Wisconsin School of Medicine. So it's a publicly available index. It's a index ranging from the 0 to 100 percentile, identifying whether that particular census tract is regarded as a deprived area or not. Yeah. So the idea here is that if the ACO is having member from those areas that are seemingly deprived based on the ADI, and as long as those ADI number belongs to either top percentiles or bottom percentile, I don't exactly recall the exact threshold. If they pass the threshold, they want to actually give additional incentive, which is equivalent of the $30 PMPM.
Yes.
Yeah. So that's something yeah. So
it's new.
It's new. It's new. It can be a big. It can be small. In many ways, I think still there is a bit of ambiguity remaining. Because ADI comes in 2 different indexes. Because one is a nationwide index, which is calculated percentiles across the nation, and there is a state level index. So they make a different percentile within the state. So last time I was digging into it, I was making a point that I'm not sure where CMS will be using nationwide index or state-wide index. Because, for example, California, so the ADI is heavily influenced by the housing price. But where the housing price is low, ADI actually percentile goes very low. That is a given fact. That's a kind of known fact for everyone. And to some degree, it makes sense because that represent economic level of the regions overall, not always overall, statistically. the problem with the California and New York is that the housing price in the very, very poor area in California can be still higher than the Midwest.
Yeah.
So that's the kind of comment I actually, that's the main reason I actually digged into health equity benchmark incentive, because my company operates ACO in California, and the California can be a very tough place to live. The housing price can be very high, but they are still, day-to-day life can be very tough, and there are a lot of underserved areas too. But if a nationwide index is being applied, we may be actually reversely affected. Even if we're treating the underserved population, if they cannot judge based on the nationwide different states, just being in California can be just the disadvantageous position. So that was my latest update. I don't know actually whether they decided to move on to the statewide or nationwide index at this point. Yeah.
Well, that was more. I learned more right there than I've heard from actually some ACO REACH awardees actually dropped out after being awarded because of the complexity, and that's something this work group is addressing, is the complexity of these payment models. And I think we ramped it up another few notches. So thank you for that education on that. And I know some other states, and great to hear that University of Wisconsin is driving this. Go Badgers, right? For anybody out there. But I know some other states like Massachusetts. We have one of our members here, Denny Brennan, is part of the Massachusetts Healthcare Data Consortium. And I did a lot of research and was asked to comment on an RFI from the Medicaid side, where Massachusetts has a lot of these socioeconomical scores that go into risk adjusting PMPMs and PMPYs, throughout 1 year segment. I believe the ACO REACH payment model might be readjusting every quarter. Is that correct, or did I misread that?
That's actually, I don't have much knowledge.
Yeah. Okay. All right. Well, anybody else, any questions? I really appreciate your time, Dr. Park.
Thanks for calling me Dr. Park. Actually, I rarely get called Dr. Park because I'm not a medical doctor in this.
all respect, and thank you so much for sharing with us, and please come on back if you want to join the work group or re-engage later. So thank you so much. I think I'll move on. We have about 15 minutes late. I'll go quickly through because it's kind of relevant what we'll be talking about next. So let me just share my screen.
Thanks a lot.
Okay, take care now. Someone give me a thumbs up when you can see my screen. Please go. My screen is paused. Stop share. One more try. Yeah, somehow. All right. No one's seeing my screen, right? And
We can see your desktop.
We see you, Michael.
See my family. Nice. Let's see. Let me stop share. Thank you, Robert. Share screen. One more try, people. It seems like my PowerPoint died. So let me wing it. So again, thank you everybody for joining. I wanted to just wrap up with our white paper that was approved by WEDI leadership late last year. It's going to go a little deeper than our first white paper, which was very 101, informative, educational, and we're going to address and attack the complexities that the new models, including ACO REACH being one of those, are really burdening. And as I mentioned, a number of payers and providers and ACOs that were awarded the ACO REACH contracts dropped out. But then we also see other things in the press where there's ACOs and they're increasing. So it's a very timely part of what we're going to be doing is producing this volume 2 of payment models white paper from simple to complex. Now, it doesn't always have to be, its complexity, but there are technologies. WEDI is here to point out and discover technologies that are going to help us, address these complexities. So it's really well suited for this work group. And again, as I mentioned, since the health equity is being infused not only at the federal level, but many states, in your state, Dr. Park, with the Cal AIM, I know they haven't really addressed a lot of the metrics yet in the early RFI, in the draft RFP, and even on the final RFP. They're still kind of waffling on what those metrics will be. And it just points to that it's a very complex and new concept for payment models and payment and risk adjustment, risk reform, all that kind of. So it's going to be great. I'm going to be looking for everybody to either sit in and learn, step up and contribute with some content, reviewing even. If you're a great editor, let's bring that to the table. If you have some context, or you can reach out to some fellow colleagues that are addressing this within your company or your state agency or your organization, please bring that to the table, offer them to come in, contact Sam or myself, but Sam would be the best way to get anything done here. And also would just like to thank everybody for joining, and the 5 staff of WEDI that just do superhero type things for a nation of payers, providers, organizations in this nation. So I really do appreciate WEDI, number one, and I appreciate everybody for joining here. So if there's no questions, we'll kind of give back a little time, but I'll wait in case there's any questions, comments, or.
Mike, it's Rob here. I just wanted to mention we got a great news earlier in the week from Michael that Liz Fowler, head of CMMI, is going to speak at our spring conference. So we were really pleased. All hats off to Michael for getting that. So we're very excited about that.
That's amazing, Mike. I don't know how you do it, but you do it. Great to know, Robert. And I think I saw Michael and Bill, and got everybody on. So thank you. All right, so let's give 10 minutes back. We can all get to our next meeting comfortably, maybe get a second coffee, or I'm on 2 pots today. It's been a long day. Thank you so much, and look forward to next month.
Thank you, Michael. And again, thank you, Dr. Park.